Okay, now I'm going to do the paravertebral scan. So
No,
if I
we'll do this on this one.
on this one,
Yeah,
okay. I remember the gentleman who was presenting the paravertebral injection did an excellent job. He really revealed to you his sentiments. Did you hear what he said? It's very scary. You go very close to the pleura. That's very true. That's why whenever I train paravertebral injections, I'm always saying, where is the tip of the needle? Because you know what you see may not be the tip of the needle. So one of the things as up-and-coming regional anesthesiologist you must be able to do is to track that tip, because that tip does the damage. So if you cannot track the tip, then your patient is at risk. So we will do the sagittal scan and the transverse scan. I will show you the anatomy. I will also show you why I have abandoned the sagittal scan, okay, because of certain reason, and why the transverse scan may be better and it's more reliable. Okay, so let me show you the transverse scan. Let's do the linear pro first. What frequency is this? 14 to 3. Can you lower the frequency a little bit? Lower frequency will be better. 11, 12, something like that. So you keep listening to what I'm saying, okay? Because we don't want too low, high a frequency, because you want to scan relatively deeper. Whereas in the brachial plexus scan, we were using something like 14 megahertz. This is something you want to use a low. So as I said, the orientation marker is going to be cranial. Can you reduce the depth for a moment? Reduce the depth a little bit? Yeah, okay. Increase it one more notch. Okay, so I'm going to scan the right mid-thoracic region, about, say, 2 finger breadths paramedian. Normally I would mark all this, but just for demonstration, you can see, I'm sure the gentleman can show you the position of the transducer. Now you can see that this machine is struggling to show me the image, right? I'm very honest. Okay, but you can see here, can you increase the depth a little bit? Okay, focus is in the right place. Okay, can you change the map if possible? Let's try and optimize this, yeah. Can you change it a little bit? A little bit brighter if you can, brighter map. No, not too bright, that's too bright. Okay, okay. What frequency are we using here? Is it on high resolution? No, put it on general. So no, okay, maybe the low is better then. Okay. So you see, these are broadband transducers. So each transducer is optimized for high, mid, and low range, depending on the bandwidth that it offers you. So you can see now that the image has already become a lot better, right? Because we've made some changes here. Can you tell me what the dynamic range is here? Sorry? I want to reduce it a little bit, reduce the dynamic range a little bit. Yeah, by reducing the dynamic range, you are making a little bit more contrast in the image. It becomes more darker. So you see here, okay, good. Now can you put it on virtual convex? Okay, good. I'm quite happy with this now. Focus up, please. This is as complicated as taking a picture with a manual camera, right? It's similar. So this young man here who's got all these fancy cameras, I also love them. I have my own toys, as I say. He has certain secrets. So you should develop these secrets as a sequence. You see, whenever you open an ultrasound machine, don't expect it to give you an image that you see in the books. Okay? The image is what you create. And the machines, depending on the machine, it'll offer you that thing. Now, what I need you to understand is, how does the anatomy change as I move from the rib to the lamina, okay, or the epidural space, the midline? Now you see here, there are two things. As the young man described before, that the ribs are more rounded. That's very true, right? The pleura is very sharp. Okay, you can see the lung sliding sign, you can see the parietal pleura. As I slide the probe medially, So I'm going to slide it like so, okay? As I slide the probe medially, look what happens first to the bony structure. It starts to become more rounded, and okay, and the pleura becomes very fuzzy. Can you see that? Okay, so this is indeed the transverse process. In fact, the transverse process anteriorly has the rib, right? Because that's the costo-transverse articulation. So now we do paravertebral blocks at this level. Now you must be saying, hello, the pleura is so fuzzy, how do I know I punctured it or not? So one reason why I don't do the injection here, this is traditionally where we do the landmark-based paravertebral injections. So your pleura will be very fuzzy. But there's a little secret that will make it clearer, is if you just tilt the probe slightly outward, see? Can you see that? Oh, now it can be seen. So what this does is it brings the beam at right angle to the pleura. That's all it is. There's anisotropy. For those of you who understand, anisotropy is an artifact. But nevertheless, the next challenge that you have is, if you want to insert a needle in plane, like so, if I were to imagine that this is my needle, and I'm going to insert it in plane from here, it'll emerge from the caudal end of the probe, right? The angle of insertion is very steep. You can't see the needle. So you can't see the pleura, you can't see the needle. It's a recipe for disaster. Of course, I can do it, but if people I'm training I want to make it consistent, reliable, safe, that's not a safe technique. Even if you use outer plane approach here, you see, outer plane approach, you only see a dot. Unless you're very proficient in tracking your tip, that again calls for this recipe for disaster. So a scan that will give you consistently, repeatably, I can't stop saying those words, right? And reliably produce images that give you anatomy as well as the needling consistently, clearly, that is desirable, okay? And that's not with the linear probe. Curve probe. Can we switch, please? Now, often they say the curve probes are for deep scanning. Low frequency equals low quality images. That used to be in the past. Today, with improved ultrasound hardware, software processing, these transducers can produce very, can you reduce the depth over 6 centimeters? Can produce exceptionally good quality images. More importantly, it gives you a very wide field of view. So you get a perspective of the whole anatomy. Where is the medial, where is the lateral, whereas you're not confined to a very narrow window where you're working in a very critical area. So over the years, we have converted ourselves to using the curved linear probe. Now this curved linear probe, Mindray, if you're listening to me, I always say this to everybody. These probes are not made for you. Why are you selling it to us? These probes are made for radiologists. You know, they are 60 millimeter footprint with a wide field of view. We don't need this kind of field of vision. We don't need it so heavy. When you start using curve probes in your clinical practice, when your hands start aching, remember me, okay? You have to train your left hand or your non-dominant hand. So when my fellows come in my department, I give them a medicine ball. You know, a little rubber ball, right? I said, when you're not doing anything, not thinking of anything, just keep squeezing this ball. By 6 months, they become really good at the hand because these are small muscles in your hand which you never use. You have to train them because otherwise it's difficult to hold the probe and keep it stationary. Okay, so the orientation marker is going to be lateral, and I'm going to start the scan from okay. So the orientation marker is going to be lateral here, okay? Now, I would have expected a little bit better images, but this is what we have. Okay, now, as I said, in order to be consistent, can we reduce the depth a little bit? maybe increase it one back again. Okay. Reduce the focus width. Now you see, like any computer, the more you flog it, the slower it gets. So if you make the focus very large, then a large area is being focused, a large amount of processing is being done by the computer, the refresh rate will come down. So there are some numbers on a machine that are often written that you don't look at. Sometimes the refresh rate is a good number to look at. Okay, now you see here, we have the first window here. What you can see is the spinous process is to the top, behind, a little bit up. Yeah, that's the shadow of the spinous process. You have a pointer I can use. Mayo. Okay. So you have the spinous process. Now, when you look at this, you can see that there is a transverse process. Okay. Yeah, thank you. Okay, can you freeze this image so that I don't have to keep holding it? Although I have quite strong hands. Okay. Now, what you see in this image is, this is lateral, this is medial. You can see the spinous process with the shadow here. Can you see that? Let me follow the spinous process. This is the lamina. This is the transverse process. The transverse process in the thoracic region is pointing backwards. Okay? This is to accommodate the rib anteriorly. In the lumbar region, if we did a lumbar scan, it'll be horizontal. Okay? The lumbar transverse process more like this. This is the rib here. So you have a large acoustic shadow, and this is the costo-transverse articulation. Okay? Right. So for pain people, this is important. Sometimes you have costochondritis, you can perform the injection there. Now, I'm going to just slide the probe down, okay? From this window to the next window. Can we unfreeze it again? Okay. So let me acquire that same window. Okay, here we go. Now I'm going to just slide the probe slightly caudad. Okay? Can you see now? You can see the pleura is sliding, right? It is a bright structure, it's moving with respiration. And that's the bright structure there. Can you freeze that for me? Right. So what you see here is, this is your spinous process, the lamina, and the posterior directed transverse process with this acoustic shadow that the young man already described before. And this is the pleura, and this is the apical part of the paravertebral space. So if you want to do paravertebral injections, if you have the skill to guide the needle to this target here laterally, that's paravertebral. You are inserted into the apex of the paravertebral space. But actually, the paravertebral space is in the dark side of the moon here. It's under the bone. So that's why he also kept saying, where is the tip of the needle? Because the tip could be in the shadow. So you may be injecting it into the vessel, into something underneath it. So when you do paravertebral injection, you must always inject saline before the drug. Saline is a surrogate for documenting that you're in the right space, and you will see pleural displacement and then incremental injection. So saline always first. Okay, so now you can see actually the paravertebral space is here, okay? And this is the transverse process. So the third window I will demonstrate to you is, can we go live again? Is the, so I start from the first one, okay? You see the rib window? Maybe I go to the lower level. This is the rib window. This is the transverse process window. And can you reduce the depth for me? Okay. And watch what happens if I just slide the probe a little bit caudad. Look at the shadow of the transverse process. It's gone, right? See this one? And gone now. Okay, can you freeze that? So what you see here is, this bony structure is the inferior articular process. So this is the spinous process, lamina, inferior articular process. This is the pleura. This is the intertransverse ligament complex. This is the foramen here, intervertebral. I showed you a picture. anterior to the inferior articular process, which is, this is anterior, is the intervertebral foramina. So in your mind's eye, you can already check where the triangular paravertebral space is, okay? So this is the true paravertebral space. If you can guide your needle slowly through here into this area, pleural puncture is not a problem. Foraminal injection is a problem if you lose track of the needle, because your needle is tangential to the pleura. So pleural puncture is not like what happens when you go like this, from back to front. Pleural puncture becomes more a problem. So you will find that if you lose track, you will find it will enter the foramen here. And if you inject a large volume, then you can get very high epidural, and so be careful. So these days we have to inject slowly and hydrodissect your way into this. Now there's no harm injecting saline here. This is actually a target now, right? It's a retroacetal space. So if you inject, put your needle here, you jiggle the needle and you see spread of saline, you'll see expansion of the ligament, okay? And if you just advance a little bit more in slow increments in the early days, as I say, then as you become more confident, you will know exactly where the needle should go. Today, there is evidence that a needle placed too lateral is not desirable. From efficacy, the efficacy is better when the needle is more medial and the injection is performed more medial. So I wouldn't say go close to here, somewhere in between over here, okay? Now, this is the traditional paravertebral anatomy, okay? But because I apologize, Shah, because the way the images are depicted, can I try the other machine? Yeah.